Does digital health expand access or widen the gap? It depends not on the technology, but on how we use it. Hi, everyone. I'm David Williams, president of strategy consulting firm Health Business Group and host of the HealthBiz Podcast, where I interview top healthcare leaders about their lives and careers. Today, I'm joined by Dr. Sarah Matt, surgeon, digital strategist, and author of The Borderless Healthcare Revolution, the definitive guide to breaking geographic barriers through technology. She's worked at Oracle Health, NextGen, and startups. We're going to discuss how to make care borderless and what it takes to make technology serve people and not the other way around. Do you like this show? If so, please subscribe and leave a review. Dr. Matt, welcome to the HealthBiz Podcast.
David, thanks for having me. Excited to be here.
Sounds great. Well, you're a surgeon first before moving into digital health. And I'm wondering, why'd you make the leap? And what's it like, as a surgeon working in digital health as opposed to maybe a technologist that you may see around you?
So I made the transition a long time ago, right after my training, which is unusual for most folks that are clinical. But what I'd say is that I actually felt rather confined at the bedside. When you're taking care of patients every day, especially in a hospital setting, you can see maybe 20 patients a day, maybe 40 if you're really jumping through hoops. But I really thought that I could make a bigger impact, and it wasn't at the bedside. How could I scale myself and be able to impact hundreds, thousands, millions, billions of people every day?
That sounds good. And would you say you have a different perspective than folks that came to it just from the technology side, perhaps without having had a clinical or certainly surgical background?
I would say that. I've worked with great and amazing engineers and technologists over the years, and they're great at what they do. And I've also worked with folks that have been 100% clinical, and they're great at what they do too. But what I'd say is that being able to see both sides is a secret sauce that not many of us have. And so when you can actually translate properly between the realities of clinical practice, the realities of a healthcare system, not just as a patient, then you can understand what the true problems are, what solutions will work and won't work, and what the right questions are to ask.
Now, I know that you stepped away from clinical practice for the most part, but I understand that you still practice perhaps part-time in certain settings, charitable, rural settings. And I'm wondering if that's the case, and how does that continued hands-on work influence how you're designing or evaluating technologies these days?
Yeah, so throughout my career, while surgery is on or off, you can only really do it or not because it's a volume practice. I've always done charity medicine, internal medicine, or urgent care. And so I still do charity internal medicine here in upstate New York. And I work at a free clinic several times a month, seeing poor whites in the middle of the opioid crisis, migrant workers, Amish, you name it. And so it's a free clinic, which is interesting because I essentially get to do third world medicine. And I get to work on paper, which is also an interesting experience as well. And what I'd say is that I think that especially on the tech side, we forget how different the rest of the world is, even if they're our neighbors. And so I think it keeps me humble and it keeps me grounded for sure.
You have a lot of insights in your new book, and perhaps you brought them from before. And I just wanted, maybe we'll pick on a couple of them throughout the course of this interview. But one of the things that you say is that access is a system, not a widget. And I'm wondering, what do you mean by that? And what are the implications?
So I do a lot of startup advising, and I can't tell you how every day I have a new founder telling me about their new amazing AI solution for healthcare. And their expertise is really 100% clinical. They haven't really done the homework, unfortunately, into the system to ask those questions like I mentioned before. And what I'd say is that I don't care how amazing your one tool is, we have a system that we have to work within. And so when we think about the realities of today, whatever tools we're bringing to that have to solve an urgent, pervasive problem, first of all. And they can't solve it in some way that's not going to work with the existing system. So until we take that system, which is unfortunately working as designed perfectly, and continue to change it and mold it over the course of time, anything that we bring into it, any tools we make, any other solutions we're bringing into the system, they have to work with what we have today. Otherwise, they're a little bit too far-fetched in a lot of, scenarios, and they're not going to get the adoption that you're hoping for.
So another one you talk about is the 5-pillar framework for healthcare access. And I wonder what that is and what makes it different. The first thing before I let you answer that I notice is that, we need like really strong, robust frameworks in healthcare. And I thought, like 5 pillars is probably about enough. Like 2 or 3 is not enough. Normally people might have 4, but it's like, yeah, 5 for, for extra. But what is it and what does it do for us?
I think this is the first time I've considered my 5 pillars maybe a 5 pillar knuckle sandwich for access. But when you think about it, especially having worked at Oracle and some of the largest tech companies in the world, it's funny because when I was working at the top levels, oftentimes we'd hear, oh, well, the technology is the easy part because that was a core competency at that tech company. And I actually think that's the case too when it comes to healthcare. And when we think about why it's hard to get patients the care they need, why it's hard to understand healthcare, why it's hard to get our children, our parents, et cetera, into the places and specialists they need, I break it down into not just, oh, tech with a tool. I break it into the 5 pillars, like you mentioned. And so to me, that's geography, financial, cultural, digital, of course, just like we were talking about, and then trust and knowledge. And if we're having a problem in the healthcare system, often one of those barriers, at least one of those barriers, is the reason why we're having a hard time with adoption, a hard time with one of the areas here, whether it's bringing patients to care, whether it's bringing providers to care, whatever that issue may be.
So as I mentioned up front in the start of the episode, digital health, it can close the access gap, but it's not automatic, and I could widen it as well. I think it's easy to point to, hey, this is great, you can bridge the divide, et cetera. But can you provide maybe an example of where digital health is doing what we might hope it would do in terms of closing that gap, but also where it actually may inadvertently widen it?
So you'll notice that of the 5 pillars, one of the barriers I bring up is digital. So it's absolutely a solution, but also a true barrier. So when COVID hit, we've all made that big change to telemedicine, virtual visits, you name it. And so if we think about I'd say the privilege is for those of us who have health insurance to see a provider like this, just basically on Zoom. That's great. I don't have to leave my office. My kids can see a doctor in between whatever. But imagine that your cell phone didn't have a lot of data. Imagine that your internet was not so great. So when you think about the amazing tools that are being brought to bear, do they work in low tech areas? Are they in the languages of people that need to use them? Are they at the reading levels of folks who are going to use them? And so while we might have the most amazing solutions, who are they leaving behind? Maybe they're not leaving you and I behind, but maybe they're leaving specific populations behind because the technology they have today doesn't meet the basic requirements of what's necessary to use that amazing tech.
So another thing that you talk about is the digital divide becoming the new waiting room. I think I have an idea of what you mean, but where do you come up with these things, first of all? And what does this one mean specifically?
Well, I have no idea where I come up with them. At least it's not another taco pun because those are usually my go-to. But what I'd say is that right now, a lot of the solutions are being put in place for patient engagement, for how are we going to reach this next population? They tend to be digital by default. What I'd suggest is that in a lot of places all over the world, there's some very non-sexy ways to engage patients. And unfortunately, if you're stuck in what I call that digital waiting room, you may have those barriers like we mentioned before, or you may have others. And so you're stuck there because the system, unfortunately, has probably decided it provided a solution. Why aren't you using it? And they've washed their hands clean of it. And unfortunately, that's where I think we end up in that waiting space for lots of different patients.
You mentioned that when you were at Oracle, you talked about how technology was the easy part. I don't think it's that easy, but maybe they've got it covered. But I'm curious what you learned there going beyond that about creating a sustainable digital models, not just something that's kind of a whiz bang to show at a conference.
So I worked with lots of great engineers over my career, but I think that when I was especially started OCI and after we acquired Cerner, working with some of the most top-notch engineering staff in the world was a great opportunity for me. And the reason I say tongue-in-cheek that the technology is the easy part is that if you and I could dream it, someone can build it. And the way that we're moving forward from a technical perspective, whether it's AI, remote patient monitoring, you name it, that part is on a fast track to daily improvement. I used to be able to make plans for 10 years from now. Now, 6 months seems like a long time, as an example. But no matter how fast we're improving these technical pieces, like I mentioned earlier, the reason the tech is the easy part is because once you actually have to adopt this and implement it into a hospital system, bring it into someone's actual home, use it every day and make sure this wearable is going to work for someone, or figure out how on earth you're going to get a therapeutic to be used by anyone 4 times a day, that's where it becomes really messy. And I'd suggest that the messiness of, unfortunately, our clinical reality is why things are so difficult. And trust is a big part of that. Right now, sometimes the technology is accelerating so fast that hospital administrators, providers, patients, consumers, they may not understand it enough to automatically say, oh, yeah, let's do that. And so we ultimately have to build that trust now as a foundation before we can even get into their hands.
So, as you say, trust is a big deal, and I see it in healthcare, but also just more generally in society. There's a real awareness of that, and it's a real, it's a real concern. So, are there specific things that either on the technology side the developers can do, or the healthcare providers can do to make the digital care feel personal and reliable, and therefore trustworthy?
So I think that everyone is a patient at some point in their life. And when we consider how we could get our care, everyone has their preferences. So there's going to be a spectrum no matter what. But I think universally, when people go and see a provider, they're expecting attention, listening, response, information, and understanding. And so if you are able to have that authentic experience, whether it's a gazillion miles away via virtual visit, whether it's right here in front of me, um, it depends on how you can meet those needs of that interaction. So what I'd say is that the tools can sometimes get in the way.
So if we put trust aside, that's a hard one. Another hard one is cost. And I think healthcare costs are going up, like crazy. We're in a period right now where, never mind whether there's ACA subsidies or not for next year, costs are just going way up for the privately insured for everybody. And digital health has become a bigger factor. So is digital health helping to drive those costs up? Is it constraining them? Or is it, like we said, with access before, it could go either direction?
I'm a firm believer that it can go in either direction. Some of the digital tools that we're putting in place can allow for more automation for our providers, administrators, et cetera, to work at the top of their license and therefore have some of those mundane tasks that they're taking a lot of time doing being done in a fashion, whether it's AI automation or by lower level providers. And I think that's helpful for the system. One of the things that's a big problem, not just on the technology side, is that we have a shortage of nurses. We have a shortage of doctors. We can't seem to make them fast enough. And it's a very difficult profession. And so as we move forward, I think that the digital tools we're bringing to bear will help extend the existing staff. It will help extend the knowledge base of those coming through the ranks. But we're going to have to find new ways to retain the people that we have in the healthcare system so that they don't decide to go into a different industry, decide to retire early, decide from the get-go that healthcare is not even worth entering. And so how can we make this profession not just better for patients, but better for the workforce, the providers, the people working in a hospital, nurses, all of them?
So, what do you see in terms of people working alongside some technologies like AI and also robotics in care delivery? Is that something we should be enthusiastic about, or is it scary?
For me, it's exciting, but at the same time, I've been building my whole career. So I've been seeing this come to bear over several years. So I don't think for me it's scary. It's a calculated risk. And ultimately, if you understand what we're taking data from, what we're doing with it, how it's going to improve things, it has built trust with me in certain circumstances. What I'd say for patients and for providers for that matter is that ultimately a lot of the AI is not what I'd call explainable. There's a lot of black boxes. And if you're a provider putting your license on the line to take care of patients, ultimately you're going to want to know where those tools are coming from, how they're being utilized, and where your liability starts and ends. And as a patient, you're going to want information. And we need to show patients that there's value in their data, but by giving us their data, they gain value from it. As an example, I give Google Maps my information all the time. I'm sure you do too. And I find value in giving them that data. On the healthcare side, I don't think we've been providing true value to patients by utilizing their data just yet.
You mentioned a black box. From some of the earlier times when AI is starting to be used, there's an awareness that some of the training data is coming from, from biased data sets. And so on the one hand, you might naively go and say, hey, we're going to get rid of bias because, the AI could be objective in a way that maybe humans can't. But they say, well, wait a minute, how do the AIs learn? And you could actually potentially echo in the AI world what's in the real world, or even entrench it even further. Where are we? How big of a problem is that algorithmic bias? And are we doing anything to correct it or make it worse?
Right now, one of the things I think is interesting is that by creating these algorithms, we're finding our existing biases within the system. The data that's been collected has probably been collected in a fashion that maybe wasn't the best in the first place, but it was taken as, this is our central database. This is great. We've done this. But people are biased, systems are biased, processes are biased. I think right now, because of the ability of these new technologies to use so much information and do it so quickly and change and evolve so quickly, folks are getting a little bit more, I'd say, anxious about the fact that they can't put their finger on how it's done. They can't put their finger on all the training data. What I'd suggest is that most of the data we've probably collected over the course of, we'll say US history in terms of healthcare has probably been taken in fashions that weren't ideal. And so if we can identify why things might be swayed one way or the other, I think that's a great first start because it shows us which populations should be included now that we know that they aren't, or that perhaps scoring or other diagnostics are not working well for specific populations. So what are we using these for? Who are they working for best? What populations perhaps we need more data on? And let's work to fill that gap.
You mentioned a little earlier on that everyone's a patient at some point. And I saw from your bio, I think you once broke your leg, something about a roller derby or something like that. And we're a patient. Do I have a little birdie told me that. Is that accurate? What happened and how does that affect, how you look at the system?
It is accurate. So I do play roller derby. And earlier this year, I had a spiral tib fib and I broke it playing roller derby. And it's interesting being a patient, and doctors are pretty much the worst patients ever. So I had this, terrible multi-bone fracture. And it was a Sunday night when I had practice and had this break. And I literally had my husband pick me up and I said, I am not going to the emergency room. Give me a couple Tylenol and we will deal with this tomorrow. He said, why aren't we going to go now? And I literally told him, I know the system and I know that the emergency room is not going to get us what we need and we'll be there all night. And so the next morning, I literally called up my mother and had her bring me to the ortho urgent, walk-in clinic that's nearby and got everything taken care of. And the PA said, are you serious? This happened last night. We have 300-pound grown men have this injury and pass out. What are you doing? And I said, well, I knew that if I got here, it would be treated appropriately and I'd get what I needed. I probably wouldn't have gotten that if I went to the emergency room. And unfortunately, even I have a hard time dealing with the healthcare system, and I'm in it, I'm creating it, I'm contributing to it. And the fact that even with all of that knowledge, accessing the things that I need is so difficult really shows that anyone who's not in that healthcare system, who is not navigating all the time, it's got to be absolutely impossible instead of almost impossible, which for patients in the US is not a great place to be.
So, Sarah, you've got a new book coming out now. It's the Borderless Healthcare Revolution. And I'm wondering kind of what went into it and then what reaction you're already getting or what you're expecting as it makes its way out into the public.
As I created this book, I really wanted to bring people together. We mentioned already that everyone has a terrible access story. So no matter where you come from, no matter how you grew up or what your situation is today, I could ask you about your parents, your kids, your friends, yourself, and we all have an access story that has not been ideal. And I think that's one of the things we can all come together on today in such a polarizing time. So my book, I wanted to be a well-researched, but not a textbook. And I wanted to have real stories so that it was accessible, if you will, for readers. And so I did tons of interviews from executive, patients, providers, you name it, all across the system. And then I did a ton of great research. And so I put this all together and really crafted this book as a way to aim at leaders in healthcare delivery on how everyone from the C-suite down to the lead nurse on the floor can improve access today, whether it's via KPIs, changes in patient care, you name it. But then also, my entire career has been in building and creating. And so how can we build in access from the get-go? And so I'm really talking to those creators, builders, founders, you name it, who are now in the space and making these solutions. To me, access is foundational, and it's going to be really great for your business and almost imperative. So I brought those two worlds together. And so far, I've had a lot of great reaction to it. It's been interesting to touch both delivery systems, academic organizations, technology companies, because everyone recognizes that healthcare access is a huge issue. They don't all know how to hit it hard. And because things are changing so fast in the economy, politically, and from a tech perspective, they're looking for ways to look at it in a different fashion. I think this is that way.
Well, that's it for yet another episode of the HealthBiz Podcast. I'm your host, David Williams, president of Health Business Group, here with Dr. Sarah Matt, author of the Borderless Healthcare Revolution. If you like what you heard, please subscribe on your favorite service. And Sarah, thanks so much for joining me.
Thanks, Dave.